And finally, Dr. Lionel Cowell, all the way from Melbourne, Australia, with lessons.
Good afternoon or good morning. I think it's 6 a.m. for me tomorrow. Okay, things I have learned. How to inject Botox. Thomas Mendonca, who trained at Smith Kettlewell, has these beautiful forceps. They allow you to inject Botox as well as with EMG guidance for horizontal recti, and though I think EMG guidance is still better for vertical recti. You just grab the muscle and it bunches it up, and it's a very nice, safe way to inject. Secondly, is Ed Buckley still here? Ed Buckley is a young man who 15 years ago suggested elevating both medials to treat the near extortropia component in convergence insufficiency. And, reverse. And he does a bimedial elevation with or without resection for the CI component, and adjustable LR-assess for the distance exotropia. And I also use the same approach in the uncommon case of acquired esotropia where distance is greater than near, if prism testing suggests the patient is at risk of near exotropia. So thank you, Ed Buckley, for this important innovation that's been around for a long time that no one seems to know about. Inferior oblique surgery. A long time ago, I switched to just a one suture inferior oblique recess. If you just do a one suture, the anterior corner, the posterior corner of the inferior oblique just slopes backwards, and the neurovascular bundle isn't under any tension. Alan Scott introduced me to his adjustable inferior oblique recession that I have modified. The important parts on this drawing, the inferior oblique itself, number one is where the anterior suture goes. Number two is where the posterior suture goes. The anterior suture from the inferior oblique will be sutured into the anterior, the anterior insertion point, and the number two, the posterior inferior oblique suture, will be sutured into the posterior insertion point as adjustables. Suturing the inferior oblique, two separate double-ended sutures. The anterior suture, scleral pass at the anterior insertion point. The posterior suture, scleral pass at the posterior insertion point. I leave the inferior oblique abutting the posterior insertion. If I want a smallish recession, I pull it forward to abut the anterior insertion if I want a large recession. And to augment the inferior oblique recession effect, I pull the suture towards the anterior insertion point, firstly releasing the sliding knot of the posterior suture, and conversely, to lessen the inferior oblique recession effect, I move the inferior oblique towards the posterior insertion, firstly releasing the sliding knot of on the anterior suture. Partial tenotomies to treat torsion. Partial tenotomies of the vertical recti, the inferior oblique, and the superior oblique. Superior oblique elevates and intorts. If I want to augment the intorsion effect or reduce the extorsion effect, I shift the superior rectus temporally. I can either do this by doing a tenotomy, bunching it up and resuturing it to the edge of the insertion, or I do a partial tenotomy at the insertion. Recessing the superior rectus will also lessen intorsion. In the picture on the right, if I want to compensate for the torsional effect that are produced with recession, I shift the new insertion to the temporal edge of the original superior rectus insertion. I drape it back from there, and that will increase the intorsion to compensate for the reduced intorsion of the recession. Superior oblique. Thanks to Joe and Robert, we know that the superior oblique has a non-overlapping dual nerve supply. The nerve supply to the torsional component and to the depression actions of the superior oblique are different. We can modify the torsional effect of the superior oblique, advance the anterior half is the Harada Ito, and to decrease the intorsion, I just excise the distal 5 millimeter of the anterior half. Inferior oblique, very similar. The anterior half is for torsion, the posterior half is for elevation, and Bert Kushner introduced this technique a long time ago, not well known. Just disinsert the anterior 2/3 of the inferior oblique at the insertion, and that will correct a fairly consistent 3 to 5 degrees of torsion without having any significant vertical effect. Resection where you didn't think you should be doing it. There is a small literature from different people showing that resection of a muscular thyroid eye disease is fairly reliable and fairly safe. You can resect or plicate, especially for vertical strabismus. I usually only do it as a second or a third procedure, and I avoid a radiologically abnormal muscle. Another surgical lesson learned is to do a small resect or plicate in Duane's, and Steve Kraft has published a few papers on this now over a quite long period of time, and I just follow his guidelines. He has very good recipes for that. Sagging lateral rectus, sagging eye syndrome. An operation that's been proposed for it is superior myopexy of the lateral rectus. You can see the lateral rectus sagging, and raising the sagging lateral rectus restores the path and the vector of the lateral rectus to normal, and that's intellectually and mechanically a very elegant procedure. But the arrow isn't working. I've had 3 bad outcomes from this operation, so I've now abandoned it. Initially, there was a good result, and then there was a fairly early regression after some weeks, and the lateral rectus anterior to the myopexy suture is superglued to the sclera, and that caused an unplanned effective recession of the lateral rectus to the point of the myopexy. This has actually been in the literature, this complication has been in the literature for a long time. It's in the English translation of the Brazilian textbook on strabismus by Preto Diaz. We have reoperated on some patients who had undergone this operation. This is just scleral farden on a horizontal rectus, and we found the muscle inserted on the sclera at the site of the sutures and adhered to the sclera from that point to the normal insertion site, just as I have found with my superior myopexy of the lateral rectus. Another lesson, look for indications to do a bimedial recession in childhood nystagmus. Of patients with childhood nystagmus, about 1/3 will have a convergence null for distance that you can demonstrate with prisms. And if they have this, they should have a trial of these prism glasses in real life. And if you can, if they have a convergence null for distance that they prefer to any of their eccentric nulls, bimedial recession is likely to also produce the same effect as the prisms, so-called artificial divergence surgery. This is case, large face turn, large tip-up head posture, and you just hold 7 diopters base out with a -1. And obviously it works very effective, can be very effective. Prescribe those glasses to wear at home, and if they're effective, you can offer a small bimedial recession. Pulley sutures. Pulley sutures useful for high-grade convergence excess and also for a near-only esotropia of an amblyoptic eye. And if I can just take you through some of this, there is the white orbital pulley material on the small hook. It's white, dense, strong, resists anterior deformation. The Merceline suture through the pulley suture, through the pulley. The suture then goes through the medial rectus, and you can see back here the 6-0 Merceline suture attaching the medial rectus to its pulley, and this creates an adduction deficit of the medial rectus similar to a scleral Farden. And that's all I have to say. I want to thank you to my teachers decades ago at Wills. I want to thank all the people in the audience here who've come to Australia to teach. I want to thank my colleagues who helped me to help my patients, to my residents and fellows who keep me challenged and honest, and to the Academy for inviting me today. Thank you.